I really like Jim's definition, much better than mine, but here's a much more boring textbook type of definition for stewardship. It's the commitment to always use antibiotics appropriately and safely, only when they are needed to treat disease, and to choose the right antibiotics and to administer them in the right way in every case. That's what I think antibiotic stewardship is. It's doing right by our patients, whether they are humans or animals. In order to frame the issue in humans specifically, we know that antibiotics have saved countless lives, but we also know, as this audience well knows, their use is not benign. We know that antibiotic resistance is occurring in populations, but also in our individual patients. And beyond resistance, I think we have to recognize that antibiotics are associated with significant adverse events. And at least 5% of hospitalized patients experience an adverse reaction to an antibiotic they receive. No matter who you ask, which study you look at, which population you look at in humans, about half of the antibiotic use is not prudent, injudicious, not appropriate, whatever word you want to use. And then finally, to make the issue much worse, very few antibiotics are being developed. The CDC has described this as one of the world's most pressing health problems. The WHO has identified antibiotic resistance as one of the 3 greatest threats to human health, although they put this out before Ebola emerged. So we know patients with resistant infections are at higher risk for disability and death. If you take a patient with a sensitive form of the bacteria that's infecting them and compare them to a patient with the resistant form and adjust and say that these 2 patients are equal in terms of their underlying severity, the one with the resistant infection will have more morbidity, higher mortality, and their care will be associated with higher costs. The costs in humans of antibiotic resistance has been estimated to be $20 billion in direct healthcare costs, but an additional $35 billion cost to society. As I mentioned, we're losing our effective antibiotics, but at the same time, we have a growing number of immunocompromised patients. We're able to do more for our patients and to treat their underlying diseases such as cancer, transplantation, et cetera. And clearly, drug development is not sufficient to deal with this threat. This is taken from the New York Times, and I have a little anecdote about this. This is several years ago. I have a former mentee who trained with us who went on to be a White House intern. And when he came back to talk to us, we asked him, so what happens at the White House? Do they read the New England Journal? Do they read Science? Do they read Nature? He goes, none of those journals matter. He said, but when something hits the New York Times, the White House goes scrambling. And this came out in the New York Times showing the decrease in the number of antibiotics approved for sale in the United States in the last 2 decades, 83 to 87 to 08, 09. And that decrease continues now. We have very, very, very few new antibiotics being developed. And why is that? It's because it's not financially viable for companies to do this. We, all of us, tell companies that we want to use less of it. Which company wants to develop a drug that the doctors and veterinarians want to use less of? They can also make a drug that somebody can take for 40 or 30 years now. Cholesterol-lowering agents, reflux drugs, Cialis, Viagra, whatever drugs that the elderly or the population that is aging, the baby boom generation, is taking for long periods of time. So I think we have, our incentives are not aligned. On the other side of the graph, you see the emergence of one of the nastiest bugs we have in hospitals now, Acinetobacter, and the proportion of those bugs that are resistant to imipenem, which is one of the last line drugs for gram-negatives. How did we get here? Here's what happens in our office. Don't forget to take a handful of complementary antibiotics on your way out. So what do we know about pediatric use in the community? This is national data looking at the number of outpatient prescriptions dispensed to the United States pediatric population. The blue line on top is systemic antibiotics. So by far, systemic antibiotics exceed the prescription of asthma medications, ADHD medications, allergy medications, pain medications, and cough and cold medications in children, by far. So it's the most commonly prescribed outpatient drug in children. If we look at some additional data, this was a nationally representative sample using the National Ambulatory Medical Care Survey, and antibiotics are prescribed in 1 of every 5 pediatric ambulatory visits. 1 in every 5. 50% were broad-spectrum antibiotics. Dr. Hutchinson's talked about using the smallest amount or the narrowest amount potentially, but 50% were broad-spectrum, mostly macrolide agents. And respiratory infections accounted for 70% of use. Let's look at the types of drugs that were being used. The 2 categories, narrow spectrum, included penicillins, ampicillin, amoxicillin, and penicillin, first-generation cephalosporins, sulfa drugs, and tetracyclines. And the broad-spectrum category included the macrolides, broad-spectrum cephalosporins, and broad-spectrum penicillins. This looks at the conditions for which antibiotics are prescribed. And I'll focus on respiratory tract infections there. And I want you to take a look at ARTIs, or acute respiratory tract infections, for which antibiotics are not indicated, and respiratory conditions for which antibiotics are not definitely indicated. Between those 2 categories, they account for about 36% of antibiotic prescriptions. So 1 in every 3 prescriptions are for an acute respiratory tract infection for which antibiotics are not indicated. It's a little bit hard to see, but I think you'll get the overall gist from looking at the trends. These are data from 3 large healthcare plans in the United States that care for children. Each of the lines on the graph represents one of the healthcare plans. Each of the graphs represents a different age category. And really what I want to give you a sense is that this is prescribing over time. And although in the youngest children, which is in figure A, we had an initial decrease about 10 years ago, probably associated with the campaign by the CDC and other organizations to make pediatricians and parents aware of the risks of antibiotic resistance and antibiotic use, that dispensing rate has plateaued. For the last 10 years, despite all of us jumping up and down at these meetings, jumping up and down at the CDC, NIH, et cetera, the prescribing rate has remained stagnant. So maybe that's a good thing, except for the fact that prescriptions for broad-spectrum antibiotics have increased. Again, these are the health plans that I mentioned. The A, B, C, and D, E represent different age groups. And what you see is the prescribing of penicillin or penicillin-like agents has decreased. And over to the far right of those graphs, you see there's been an increase in 3rd-generation cephalosporin use and macrolide use. These are significant increases. So yes, our rate of prescribing has remained steady, but our rate of prescribing broad-spectrum agents has increased. One of my favorite words is variability, because variability tells me none of us know what we're doing. So here is data looking at outpatient antibacterial use in the United States and 27 European countries. This is now 2004 data, so it's a little outdated, but it hasn't changed much. Look where the United States is. So I don't know if you've been aware of what's been happening in Greece, Italy, and France recently, but that is not good company to be keeping in terms of financial crisis. And I don't know whether it's good company to keep in terms of antibiotic prescribing. But really what I want to point out is that the variability tells us something. It is not like patients in the Netherlands are dying at higher rates than patients in the United States, or patients in Slovenia, or patients in Italy. So there is, what is the right amount of antibiotics? And Dr. Hutchinson referred to this, and I don't know what it is, but clearly the variability is too big to explain differences in outcomes. This is looking at the variability in the United States. This is from Laura Hicks at the CDC, some fabulous work published in the New England Journal of Medicine last year. The lighter areas represent lower rates of prescribing. The darker areas, the darker shading represents higher areas of prescribing. Look at this variability. Patients are not getting better care in the darker shaded areas, and patients in the lighter shaded areas are not getting worse care. But yet the antibiotic prescriptions vary significantly. I think it's food for thought for all of us. This just came out, again, looking at national data in pediatrics, the percent of ambulatory visits for each of these conditions, Just to orient the non-clinicians, AOM is otitis media, ear infections, the most common condition for which we prescribe antibiotics in kids, bronchitis, pharyngitis, sinusitis, upper respiratory tract infections. And you see that there's really been no change in the percent of ambulatory visits. So kids are not seeing doctors more or less for these types of things, and antibiotic prescribing has not changed. These are essentially flat lines across all these conditions in terms of prescribing. So this year's data suggests, again, similar patterns, no decrease in prescribing. If we look at conditions for which we prescribe in children that we expect bacterial pathogens, so focus where it says visits with expected bacterial pathogens in thousands, bronchitis and upper respiratory tract infections in children are mostly viral. There are no bacterial pathogens that account for those conditions, and yet we see significant prescribing across all age categories for conditions for which we do not need to prescribe. The CDC last year put out a landmark report on actions to combat resistance, and really I want to focus today on action number 3, which is improving antibiotic use and stewardship, perhaps the most important action needed. The other actions listed there are preventing infections and preventing the spread of resistance through immunizing our patients, infection control, safe food preparation and hand washing, tracking infections, and development of drugs and diagnostic tests. But I mentioned already some of the challenges around developing drugs. The use of antibiotics is the single most important factor leading to antibiotic resistance and the single most important action needed to greatly slow the development. Along the lines of what Dr. Hutchison said, use, use, use. I think if we focus on use, eventually resistance will follow. I mean, I could put many slides like this up there. The leading organizations in this country around healthcare epidemiology, infectious diseases, and pediatrics have all called for increased focus on protecting antibiotics and developing antimicrobial stewardship. I want to show you our experience with antibiotic stewardship in the community setting, because I really think there are some lessons to be learned from this work. I work at the Children's Hospital of Philadelphia. We have a care network that includes 5 urban academic practices, 24 private practices that are part of our network. And what we have in common is a common electronic health record. And again, variability. I'm going to air our dirty laundry. Here's the antibiotic prescribing for sick visits in our primary care practices. Each of those lines represents a different pediatrician's office. And you see the rate of antibiotic prescribing at office number 5 is under 20%, and at office number 25 is above 30%. These are similar patients. This is the same network. Look at broad spectrum antibiotic prescribing. Tremendous variability, tremendous variability. Again, this is adjusting for different age of patients, sex, race, Medicaid status, and we excluded kids who had complex conditions. Here's what I thought was most interesting. Look at the diagnosis rate. So the rate at which physicians were giving a diagnosis of otitis media or ear infections. This, if I superimposed it on the prescribing graph, matches identically. So what does it tell us? Physicians were giving diagnoses in order to provide antibiotics, to justify the prescription of antibiotics. Because there is not such a significant rate of otitis media, a difference in rate of otitis media across these practices. This is practice A is down the street from practice B. Variability in broad spectrum antibiotics for otitis media. Same story. We got to rein in this variability and try to figure out why practice 15 is prescribing or 16 prescribing broad spectrum while the other practices are doing a better job. So to summarize our data from our outpatient setting, antibiotic prescribing at sick visit varies significantly across practice sites. Broad spectrum antibiotic prescribing varies significantly as well, but the rate of diagnoses varies significantly. And very few folks are adhering to prescribing guidelines. So this was our attempt at stewardship. This was published last year. It was an intervention to try to improve on that variability that I just showed you. We took 25 practices and we randomized them. We excluded 7 of the practices, 5 of the academic practices which have residents and teaching faculty because we thought those were unique in some aspects and didn't want to include them in this study. 2 practices refused participation. They CHOP fired those practices. 18, that was a joke. Sorry. 18 practices were randomized. So we randomized 18 practices and 170 doctors. 9 of the practices received the intervention. 9 received no intervention. So what did we do? We developed guidelines, educated, and then provided audit and feedback, what was known by our pediatricians as you're giving us report cards. We looked at the common infections. We did not just focus on ICD-9 codes, but we used patient chart reviews. What did we do? We had 12 months of baseline data on prescribing. We went to the sites and made a presentation on judicious, prudent antibiotic use, and then we gave report cards on individual sites prescribing, and then followed the sites prescribing 12 months after the feedback ended. So let me give you an example of one of these report cards, and I'll walk you through this. This is one for sinusitis, and the 3 colors represent a different time period in the study. Baseline, quarter 1 is the maroon, quarter 2 is the green, and you see there data for yourself as a prescriber, your practice, meaning the other folks in your group, and then your network, so the other folks in the CHOP network, and you can compare yourself to the others on a quarterly basis. What did we see? We saw a significant decrease in the intervention practices compared to the control practices in terms of antibiotic prescribing post-intervention. And for all the different conditions, except for pharyngitis, the one at the bottom, we saw statistically significant decreases. For sinusitis, it was close to a 40% decrease in broad-spectrum antibiotic prescribing. All right. What do you think happened when we stopped giving the report cards? Ready? This is very disappointing. I chuckle and I laugh. This is very, very disappointing. We just published this October 10th. This speaks volumes about the difficulties in antibiotic stewardship. I really don't know what the answer is after this study. Is it constant feedback? Is it mandates by the government, by the CDC? Something. It clearly is that folks responded to being compared to other folks and being watched. But once you stop watching, they go back to their baseline behaviors. We sent a medical sociologist who works with us because I finally realized that numbers are not going to help me change this problem. We hired a medical sociologist, and she does all this stuff around qualitative research that I have no idea how she does and what it means. She used a modified grounded theory approach. But she went out and she talked to all these physicians that participated in the study. And here's what she got. Here's some of the themes. Deep skepticism of the audit and feedback reports, as if they were not generated by a computer. I don't know what the skepticism could be about. Did I fix the reports? Respondents ignored reports or expressed distrust about them. One respondent admitted to gaming behavior. That means giving a diagnosis in order to give an antibiotic that would justify giving the antibiotic. And if one admitted it, you know there are others who didn't admit it. They recognized it was a problem, but it was driven by the behaviors of non-pediatric physicians and you all in the animal setting. Parent pressure for antibiotics was identified by all respondents, and many of them said they caved to parental pressures for social reasons. So enough about resistance. I want to open up a little bit of a dialogue around some of the other effects of antibiotics that we're just beginning to grasp that go beyond resistance. This was a cover in New York Times, germs, and it really was an introduction to the microbiome, the bacteria that live with us that clearly outnumber the number of human or animal cells. This was a call by Marty Blaser at NYU to stop the killing of beneficial bacteria with the use of antibiotics. And what was he talking about? He's done some pioneer work looking at the impact of antibiotics on the microbiome. So this is the impact of antibiotic administration on the bacterial community of the colon, the human colon. And if you see all the way to that side, depending on where you're standing, right or left, there's a different milieu of bacteria, nice variability, different colors, different shapes. Once you provide antibiotics, you see that you select out for certain types of bacteria while eliminating the others. There's an end of antibiotic treatment, and look how long it takes for the milieu to return to what it looked like in baseline. You know what that time interval is? 2 years. This was a study in children, which I think should provoke a lot of thought and concern. This was a study done using a United Kingdom database. The United Kingdom has National Health Service, and many of the pediatricians are on an electronic health record. Over 1 million kids were in this birth cohort. And what it looked like is what it looked at is the association between antibiotics and the development of inflammatory bowel disease, also known as Crohn's disease or ulcerative colitis. What's the thinking behind it? That Crohn's or ulcerative colitis are autoimmune diseases that somehow are triggered by an interaction of the microbes with the gastrointestinal mucosa. So the hypothesis is that antibiotics given to children somehow alter the milieu enough to create circumstances for autoimmunity and inflammatory bowel disease. The top, the red line, shows the exposed, meaning kids who got antibiotics, and the blue, the unexposed. And over time, you see, as the years go on, the risk of inflammatory bowel disease increases in children who got antibiotics compared to children who didn't. The lower graph gives even more credence to this finding. There's a dose response. The more antibiotics you give, the greater the risk of a child developing inflammatory bowel disease. I'm wrapping up. This has received a lot of attention. Could antibiotics be a factor in obesity? Again, sort of changes in the microbiome predisposing to obesity. This was a mouse study published in Nature several years ago, showing that if you feed mice antibiotics, that their fat mass, body fat, are greater and increased. What these folks also found in that study is not only are the mice fatter, they have changes in hormone levels related to metabolism, their microbiome is changed, they have epigenetic changes in copies of genes involved in metabolizing carbohydrates to short-chain fatty acids, alterations in hepatic metabolism of lipids and cholesterol, and increase in colonic levels of short-chain fatty acids. I don't think I need to tell you that antibiotic resistance is a critical public health issue. I think antimicrobial stewardship and reducing use is the key to reducing resistance. Antibiotic prescribing is really variable in the community setting and often inappropriate. I think we need to figure out ways to develop community antimicrobial stewardship programs that will work. And I think we're really opening Pandora's box by changing the microbiome, and we're only just beginning to understand those changes. Thank you very much.